audio like that. Can you increase the volume? Dr. Caroline, am I audible there? Yeah, now I can hear you. Yes. Am I audible? Yeah, okay. So, Dr. Nidhi will be starting the surgery and she will be also speaking along with that. Yeah. I will just hand over the mic to Dr. Nidhi while I prepare for the next case, which is going to be iris claw implantation. And here you can see it's a posterior subcapsular cataract. If Dr. Nidhi can focus on that, and always there is a doubt whether it is a posterior polar or it's a posterior subcapsular cataract. Okay, over to Dr. Nidhi.
Am I audible? Am I audible? नहीं माइक मैं इसको लगाऊं माइक लावायचं का मॅडम माइक लावायचं का मॅडम ओके दुसरी सांग just 1 second. Am I audible, doctor? Hello. Hi, doctor. Hi, Caroline. It's So I have just made the incisions and put the viscoelastic. I am starting with the CCC. I aim for 5 to 5.5 capsule rexes, not a small one in softer cataracts. This is cystotome. Generally we use if we do the CCC from the main port, if you can it has a bend in the center so that it does not press on the lower lip, so that it maintains the chamber better. Of course, you can go with the normal cystotome also. Now, my current plan in this case, because there is hardly any nuclear component, I will try for a carousel technique. So, for that my first thing is having a good hydrodissection. So, I got first wave. Oops. Delineate. I now try for the hydrodelineation. There is some nuclear component, so let us see if I am able to get. Okay. What is a big ring? So, if I am able to do the carousel technique, otherwise my backup plan will be the trench end divide. So, this is a 1 millimeter Sinskey that we use. Yeah, it is sharp for all the chopping, and as well as for trenching it is able to reach at the base. In the softer cataracts, ensure a proper rotation to have a easier cortical removal at the end. Scalp मध्ये power कमी करा 40.
Can you show the setting?
Dr. Nidhi, this is Dr. Claudia Palacio. I want to ask you, sometimes soft cataracts are difficult to handle. Do you use low settings?
Yes, yes. So, soft cataracts can be very tricky. Generally, what technique that I use is, if there is some nuclear component, at least NS1, I go for trenching and division, and if there is absolutely no nuclear component, then I go for carousel technique. So, on that I do hydrodissection and then hydrodelineation. But in this case, there is just a little nuclear component. So, the ring is quite big. So, the endonucleus is big. So, I am not sure if I will be able to do the carousel, but I will try. So, currently I am operating on Centurion. Can you show the settings?
Okay, we can see that.
Yeah. So, in quadrant removal, I kept the power of 10. So, now I will vacuum is high, visco on the cornea. Oh, it is a polar, posterior polar cataract. Dr. Saurabh, it's a drop.
Fine, we'll manage. You can do anti-vitrectomy.
Oh, okay.
Okay.
So it was a posterior polar.
Yeah. So, it looked like a posterior subcapsular. Our assessment was wrong.
Anti-vitrectomy and remove the cortex.
This is a big probability when we have a polar posterior cataract.
So, I'll go ahead with anterior vitrectomy.
What kind of anesthesia are you using?
I have given peribulbar. So, for the anterior vitrectomy, first I will do the vitrectomy in the cut IA mode, and then I will go to the IA cut mode, and then I will remove the cortex, and then I will put the lens in the sulcus. I will post the patient for the phacofrag, most likely tomorrow by the retina surgeon. Is the rent visible there? Let's see. बॉटल हाइट कमी के लिए ऑन केलं ओके सो आई एम स्टार्टिंग कट आइए हां कट आइए के केलं 3 piece ready थे
First, cutting vitreous.
yes
And
yes
then
yes आइए कट what is the vacuum now I have gone to the IA cut mode so our first aim is to remove the vitreous
first cut vitreous and then manage the cortex. I like that way to manage these complications.
sorry I didn't understand what
I mean that with the vitrector, you can both things.
yeah we can do IA with this so if there is vitreous during the cortex removal then also you can go to cut mode so it is IA after that there is a cut mode you can use bimanual also after you have done the vitrectomy don't keep the vacuum too low because the cut comes very faster in this if you are using vitrectomy machine cut आइए cut आइए yes so I'll go to cut IA again because there is vitreous still okay IA cut
Sometimes we don't know that these two functions of the vitrector exist in the center of the machine.
yeah most of the advanced machine they have both the options of cut IA and IA cut so if you want to remove the cortex you can go to IA cut mode so the aspiration will come first and you press the full then the vitrectomy will act advantage is that you need not change the probe again and again so if it is there in your machine you should utilize it so there is some vitreous cut आइए आइए कर नहीं था कटाइए कटाइए I will use the IVTA now, triamcinolone, to confirm that there is no vitreous in the anterior chamber. It is a big rent actually. So, there was a misjudgment on my part to
Always you have a rupture of capsular posterior.
yes, sorry, please can you repeat?
If you use Gamcinolone, always you have the rupture.
No, I am.
Do you always use triamcinolone?
It is better always. Before placing the lens, I want to be sure that there is no vitreous in the anterior chamber, because that affects the prognosis of the patient.
Yes, of course.
So, we will get a 3-piece. मी घातलेच नाही कधी 3-piece घालते द्या लोड करता येते. So, there is no vitreous. I will just confirm iris repositor.
Are you going to capture the optic in the rexis?
I will put first in the sulcus and then we will see. I will decrease the power by 1 diopter. So, mostly I am not planning now to do optic capture. If I had kept the same power, I would have done the optic capture. It is better to do optic capture, but I have the lens power that I have is 1 diopter less.
How do you change the power of the IL when you put it on the sulcus?
If you put in the sulcus and you are not doing any optic capture, then you decrease by 1 diopter generally, but this is for depending upon the IOL power also. So, this is for the standard IOL power 17 to 25 kind of. If it is if you are doing optic capture, then you do not need to change the IOL power, because the optic will be in the bag, and yeah, for the lesser and the lower and this bigger powers it is different. I'll enlarge the incision. लोड करायला चालना देता है का?
Patient,
Yes,
how old is the patient?
45-year-old.
It's strange with this kind of cataract.
Life surgery was a interesting place to have this wrong decision.
Capsular
Yeah. त्याच्या हे हॅप्टिक मागचा काढला आहे ना. सरांना सांगताय का एकदा 3 पीस पहिल्यांदा घालतोय तिकडे थांबायला सांग ना. 3 पीस आई एम पुटिंग पहली बार डाल रही हूँ, देख लो जस्ट देख लो. हाँ AC.
What kind of injector are you using?
It's a B cartridge.
It's a B cartridge. Sinsky. I'll do the visco wash first, then I'll use a pilocarpine. I just have to do now the visco wash, and I'll probably suture the main port because you've done vitrectomy. Till then you can go to the other microscope where Dr. Saurabh is going to put a iris claw IOL.
Thank you very much.
So, Dr. Dr. Caroline?
Yes.
Yeah.
I just want to tell Vicky that I think that best surgeons are the ones that solve the complications. So she did an excellent job.
Yes, I think perfectly done. And in this case, I think that is what is expected from an anterior segment surgeon. If a vitreoretinal surgeon is immediately available, of course, we can take the patient immediately. Okay, so we'll move on to this case. This is again another patient where patient was left aphakic because of an intraoperative complication. I hope the video is visible there. Dr. Caroline? Yeah. So, what I have done so far is I have done a scleral tunnel here, place this iris claw in the anterior chamber, and I have made 2 incisions which are around 180 degrees apart. Okay. I will just show the incisions. So, this is the first incision on this side, and then this is the second incision here. Maushi halunaka. This is the second incision here. Okay. And if you notice, the incisions are posterior, not limbal but posterior to the limbus, which helps me in better enclavation. Okay. No, Isinski. I have already done the anterior vitrectomy. This is the iris claw forceps which I am going to use. First, my left hand will go inside. So, the Sinsky is in a position to enclave. I hold the iris claw here and then enclave it. The patient is a bit uncooperative, moving his head. Did you see the first enclavation part?
Yes, yes.
Okay. And you can also check if it is perfect or not by just moving the IOL to another side, and you can see the iris moves. So it's good. Now when we enclave the second haptic, the usual issues are is that we have to negotiate the iris, and second, many times the AC shallows a bit, which is a bit scary for anterior segment surgeons, but that is something we have to get used to. Maushi, don't move. So again my right hand should go inside, so I don't have to search for the incision later. The claw goes in, it goes in, and then I will Maushi tuck in the second haptic. झालं मावशी, हलू नका. Was that clear? And you can see it's nicely enclaved. I will just zoom and show. You can see that both haptics are nicely enclaved. You can see the enclavation also there. Okay. Now before I close, I must do a peripheral iridectomy. Maushi, हलू नका. 5 मिनिटं राहिली फक्त. So I will ask for the vitrectomy cutter. Now I have to keep low vacuum, so make it 150. Okay, so I go in.
Aspiration 10.
Yeah, aspiration is 10 cc.
Cataract 200.
Yeah.
2000.
Reduce the bottle height. So they have kept a very high bottle height. That is why the AC became very deep. Reduce, azun, bas. So I have reduced the bottle height now. That's the cutter which goes in. And now I am going to make a peripheral iridectomy. So that's it. The cut is made. Okay. Just checking for it. हलू नका. कट रेट कमी कर. मावशी हलू नका.
1000.
Yeah. I'll just go in and confirm once again because I am just not sure. Yeah. Now I am sure of the PI which is made. I am just washing off a little bit of visco which is there. I can do it from the main incision as well. You can see the peripheral PI here. Any questions, Caroline? Am I audible there? आवाज येतोय का? Am I audible?
What kind of patient do you consider is the best patient to put this lens?
For the initially?
Yes.
Yeah, so any patient where you can have a small pupil like this, already a vitrectomized eye. For the beginner, I would choose a patient where probably there is some PC still there. So chances of dropping of the IOL are less. Initially, you can also thread around the one of the haptics, the diathermy there, so that even if initially for beginners sometimes you tend to not do enclavation perfectly, and then it might just hang or might drop into the vitreous. So, in that case you can put a thread around. Yeah. Okay. So, that is the end of the surgery from here. And the A constant when you do retropupillary fixation is 117.8, which I use. So, if you are using say 119.0 for PCIL, you have to reduce it by around 1 diopter or maybe 1.25 diopters. Can you increase the volume please? I can't hear. Yes, Dr. Caroline, can you repeat the question?
Yes, what is the possibility of
I am sorry, I couldn't hear.
the possibility of the atrophy of the iris?
No, the iris claw lens we have been following for last almost 10 to 15 years, and it works quite well. The disenclavation which might be thought of when we are having in the post-op period, but usually we find that when the first enclavation was not done well. So, if the first enclavation was done well, we hardly see any dislocation of these IOLs, and many surgeons, yeah, please go ahead.
Now, in the case that you have to explant the iris claw, is easy or it
Yeah, it's tough when we, particularly when we do the retropupillary iris claw, it's tough because you have to go from behind and then try to release the iris from it, but it's tough. Sometimes you may have to just cut little bit of iris to remove it, but when you have done an anterior iris claw enclavation, it's easier to remove the IOL. Yeah, it's difficult but can be done, and usually we don't have to remove it unless at one end it has already dislocated or released. In that case it's easier because you can just cut little bit of iris around the enclavation, or you can go from behind and just push the iris tissue up and release the iris claw IOL. If yeah, go ahead.
and do you use iris claw in children?
Yeah, so I have personally not used iris claw in many children, but there are surgeons around who are using it in particularly patients having subluxated or dislocated lenses in children, and they claim to have fairly good results in the long term follow up as well, equivalent to a scleral fixated IOL. So, when we say iris claw, we have to compare it with a scleral fixated IOL and not with the PCIL in the bag, because I think PCIL in the bag is the best place for the IOL to be with least amount of complications, but whenever there is lack of support of the bag, we have to either go for a iris claw IOL, ACIL or the scleral fixated IOL, and amongst these I think iris claw and SFIL are almost equal, having equal results. Iris claw for anterior segment surgeon is easier to do, easier to master with less surgical skill needed. Scleral fixated IOL requires little bit of more learning curve, I would say. So, a well done iris claw lens will have a very equivalent result to a well done scleral fixated IOL. Drape kara please. Yes, so we are now moving to the next case, which is again a complex case. I think it's the mature cataract. Yeah, please drape the patient. So, the next case is a mature cataract with small pupil with pseudo exfoliation and very shallow anterior chamber. I think what is the anterior chamber depth?
1.92.
So, the anterior chamber depth is just 1.2 millimeter, 1.92 millimeter, which is very, very shallow, and a lot of things we can expect. One thing is there is going to be a lot of intumations, so we may have rhexis going out. Second, when we have pseudo exfoliation, we expect the zonules can be quite weak, and the pupil is also non-dilating. So, when you have pseudo exfoliation with non-dilating pupil, that is another a difficult combination to tackle. It is going to be a hard cataract, the patient is old, and let us see how it goes.
Pseudoexfoliation is common in India.
Yeah, pseudo exfoliation is very common. Is it common there also? Yeah, pseudo exfoliation is common in Mexico as well.
Yes, yes, it's common
Yeah.
in some patients.
So, a lot of old patients that we see, they have some component of pseudo exfoliation. Anvati work kara machi, work kara, Anvati work kara. Next case, I think SICS. So, after this case, we are planning to do a small incision cataract surgery, manual SICS. After this case, so in this case, we like to do phaco, and let us see how it goes, because it is going to be a tough case again. Yes. Table work है बस. Is it focused over there? Yeah. So, just want to show the same things. You can see there is pseudo exfoliation and non-dilating pupil. The anterior chamber is very, very shallow. Give a different MVR. This is a bad MVR. दूसरा दे. So, very shallow anterior chamber, and you can see it is a white cataract. So, this is the 23 gauge MVR which I am going to use, but in this case I am going to insert a B hex, which is a pupil expansion ring. So, I have enlarged that little bit. So, I am going though I sit at the head end, I take a temporal incision here, and I have to be very careful here to make a good, oh yes, highly coat. Okay, it is very shallow. You can see my scissor or the blade was almost touching the anterior capsule. Now, I am going to stain. BDA करे.
What kind of OBD you prefer in these cases?
Yeah, so I am going to use Hylucoat, which is similar to Viscoat, which is given by Alcon. Yeah, so it is a dispersive, but it is more viscous than even Viscoat. Okay, so now what I am going to do is I am going to put a B hex. Now, here there are couple of challenges with this. One is that if it is a very rigid pupil, I may have to do stretch pupilloplasty in between. Let us see how it goes. Do you have this pupil expansion device there? Yeah, so this,
Rings.
yeah, so it has 6 flanges as you can see, and it's made up of I think nitinol kind of material. This is an invention of an Indian ophthalmologist, Dr. Suven Bhattacharjee. So the alternate flanges, they will go underneath the iris. It's a uniplanar design. So these knobs which are there will help me in holding, and then I will be tucking it inside or the under the iris. So more than pupil expander, it's more of a pupil retainer. Okay, any advices for the capsulorhexis here?
It looks very easy in your hands.
Okay, so this is a very intumescent cataract as you can see. So the first thing which I am going to do is to give a cruciate incision right in the center of the lens. And then I am going to try and aspirate some of this lenticular material. So here it goes. Okay. So one side the material is out. Okay. So I have taken out quite bit of intralenticular material now to reduce the pressure. Now what I do is I do some peripheral stroking. Forceps please. This is to take out the fluid pockets which are there. Now another issue here is that under the iris it is not stained. So here I have lifted the flap. Am I audible there? Dr. Caroline?
Yes?
Yeah, am I audible?
Sorry, I don't understand.
Am I audible there? Can you hear me?
Yes, we
Yes.
are.
Okay, okay, okay. Because there is lot of silence there, so I thought whether I am. Okay. Any questions so far?
Sinski that you are using. What can you tell us about that?
This Sinski?
Yes.
Yeah. So this is like a Sinski dialer, but it's 1.5 millimeter long. So I modified it and I use it as a chopper. Now I go in, it's still shallow AC, 2.8 D less. I have to be very careful about the endothelium as well here. If you can show them the parameters. Oh yes. Okay. Now what I am going to do here is first I will make small trench because it's a very dense cataract, as you can see. माझे सेटिंग लावलेत ना रे मी IOP. Okay, so I am working on 36 IOP here. Okay, once I have a deep trench, I will go to the chop, burying it deep using this Sinski to separate. Okay, you could see that separation there.
Yes. Doctor, it is interesting that during your surgery you rotated upside.
Okay, so I am doing multiple chops here. I am doing multiple chops. So this long Sinski helps me in doing the chop till the posterior plate. I hope it is clear. It's a balanced tip.
Okay.
Yeah. So that's why if you see I am using 70% power only. And now once I take out one piece, what I am going to do is I am going to replenish the viscoelastic. I want a very clear cornea post-op day. So here goes again Hylucoat, which is a heavy dispersive agent, and what I do is that I put some methyl cellulose or HPMC underneath into the bag, so that pushes the Hylucoat further on the endothelium. Now I shift generally to a shorter Sinski. Now I have already chopped the pieces, so I just have to emulsify them one by one, trying to emulsify them at the iris plane as far as possible. IP on है ना 95. So I have added some IP. Any comments about the technique used?
You never do a direct chop without a trend?
Yeah, direct chop without a trench can be done, but when you have this kind of nucleus, it's important to judge the depth at which you are going. And when you are doing primary chop, if you misjudge the depth, then it becomes a problem. So generally I do a kind of a half trench and then I chop. So as you can see,
On the hardness of the cataract?
yeah, halu naka. Yeah. So this is a quite hard cataract, as you can observe. What I am observing here is also the bubbles which are there underneath the endothelium. Can you watch those bubbles? So that is the sentinel bubble. So if it stays there, I know that the endothelium is well protected by the viscoat or hylucoat. I am trying to emulsify at the plane of the iris always, but of course here the anterior chamber is also very shallow. I will. Okay. So the last part is removal of the cortex, which is going to be very minimal. I just have to be careful not to pull the bag.
Was very stable, right?
Yes, it was very nice, and that's the beauty of Centurion, that even with low IOP you can use high vacuum and still be comfortable. Halunaka. It's late night here, so most of the patients I think are sleeping in between.
I was ring that you put in the pupil.
Yeah. I couldn't hear the question.
The ring of the pupil is single use.
This B-hex, yeah, it is supposed to be single use, though we can do ETO sterilization and use it till it gets deformed, but generally we cannot use it for very multiple times. Change the bag. But like in India it's quite less expensive as compared to the other pupil expansion devices like Malugin ring, and works quite well. Iris hooks is another option that we have, and it's pretty good option and almost versatile, like you can use it in all cases. But B-hex is I would say I'm more comfortable because we don't have to make more incisions. And I generally use it in topical as well, topical anesthesia. So in this case the patient was not very cooperative, she also had some head nodding, so we decided to block the patient, but otherwise we can use this device even on topical anesthesia. So once the IL is inside, I am going to remove this B-hex, and it's very easy. So what we have to do is just pull in the flanges like this, and it's released from the margin of the iris and just pull it out, very easy. And no sphincter tears as such with this device, because it's very I would say flexible, and that's why if the pupil is too rigid, we have to in fact do some stretch pupilloplasty before we use the device. Now you can see I am removing the hylucoat which is still stuck to the endothelium. That means this patient is going to have very nice cornea tomorrow as well.
Yes, sure.
And what was the CDE like? CD is the 39. So CD is the indicator like how much energy I have used, but it is not the only indicator which will tell you how the cornea will be, because it depends where you have used the energy. If you use same energy under the endothelium very close to it, it's very dangerous, but if you go and do phacoemulsification at the iris plane, it will be much safer. So CD is just one of the indicators, but most important is how you use that energy.
Can we shift this?
Yeah. Okay, Dr. Caroline, now we are shifting to the other table where manual small incision cataract surgery is being done. I will speak. Okay, can you center the microscope there? Yeah. Dr. Caroline, any questions about this case?
Oh, it's a beautiful surgery.
Thank you, Dr. Caroline. And I will just hydrate the incision, and then Dr. Umesh, my colleague, he is excellent surgeon. He is going to show manual small incision cataract surgery. Now he is going to show how to make the incision. Is manual small incision cataract surgery very common in Mexico? Okay, so he is going to use a blade to create partial groove here. Generally we use around 6 millimeter long scleral incision. This is a intumescent mature cataract. He has already done the capsulorhexis, as you can see there. Dr. Caroline, am I audible?
Yes.
Yeah, okay. So now he is using crescent blade to make the tunnel. Now first thing is to create the tunnel till the cornea. You can see it's around 1.5 millimeter from the limbus, and then inside the limbus it's 1.5 millimeter. So this is perfect. And once you create the first scleral incision, now what he is doing is he is going into the cornea first, and then as he comes out he enlarges the tunnel. So cut while coming out. That is being perfectly demonstrated. And the depth of the tunnel is very important here. You can see the crescent is just visible. So it should not be easily visible. Also it should not be completely invisible. Otherwise you will make either very superficial or very deep tunnel. So I think that has been beautifully demonstrated. So crescent goes into the cornea first, and then while coming out it cuts. So for very large nucleus you can also make side pockets. So nice big capsulorhexis done here, which is very useful, very important for small incision cataract surgery. So you should make at least 5 to 5.5 millimeter capsulorhexis for small incision cataract surgery. Now the entry using the keratome, it's a 2.8 keratome, and the entry is made. And what you have to try is now cut while going in. So it is other way round. When you are making the tunnel, it is cutting while coming out. Now cut while going in. On both sides, try to make the inner tunnel as parallel to the limbus as possible for having the best, least astigmatism as possible. Perfectly done. So the next case which I am going to show is a toric IL case. So once Dr. Umesh takes out the nucleus, I will show how to mark the patient. You can ask the question. Now he is going to prolapse the nucleus out, you can see, using the hydro itself. So push some fluid on one side and pole comes out. Now both the poles are out. The nucleus is in the anterior chamber. Can you center little bit? Yeah, perfect. That is perfect. He has also taken a superrectus bridle. You can see he is just pushing the viscoelastic around the nucleus. So as to have complete coat of the viscoelastic under the nucleus as well as under the endothelium. Now the next part of nucleus removal. So he is going to use the sandwich technique here using wire vectis and then Sinski over it. So he is going to sandwich the nucleus between the two incisions there, and then he will pull it out. Beautifully done. The scleral tunnel was perfect, so it came out very, very easily. Very nicely done. And now the next part is wash of the cortex and then placement of the IOL. So in the meanwhile, I will just show how to mark for a toric IOL as well. Patient ना जरा बसवता आणि हा कॅमेरा त्या साईडला घेऊन जा. आणि माझा मोबाईल आणि हे घेऊन ये. पेन मार्कर घे. पेशंटना बसवून ठेवा. So Dr. Caroline, any questions about small incision cataract surgery?
Yes, doctor, I want to ask you those two questions. Cataract surgery has undergone dramatic changes over the last 20 years. Most surgeons started performing reduced incision size, but now you are performing a surgery with a large incision and it is successful. So
Okay, I missed the last part. Can you repeat the last part, Dr. Caroline? We missed the last part. Dr. Caroline?
I was telling you that cataract surgery has undergone dramatic changes.
Yeah.
More surgeons started looking at reduced incision size.
Yeah.
And this that you are performing is with a large incision. I want that you tell us what are the advantages of this technique.
Yeah, so though we are performing it through large incision, if we perform it well within the the area where you create least amount of astigmatism, it does quite well, and it's very useful for difficult cases as well, where you don't want to damage the endothelium. In those cases, I think this works quite well. Though of course, as you rightly said, many of the surgeons are now moving to small incision, the phacoemulsification surgery, and as I showed in the previous case, even the toughest cases we can tackle using phaco. So you have to balance between the two according to the patient's needs. Okay.
Which profile of patient you choose this kind of surgery?
So any patient who has got very hard cataract with poor endothelial, even in cases where the zonules are quite weak, zonules are very, very weak. So in such cases, I would prefer a small incision cataract surgery, remove the nucleus, and then put the IOL. So it's like triad of things, like you have to assess the hardness of the cataract, endothelial or corneal clarity or endothelial weakness, and zonular weakness. So if you see two of them very severe, in the very severe form, then small incision cataract surgery might be safer for that patient. Okay.
How many surgeries we have to perform to dominate this technique?
How many?
How many cases, I think, yeah. How many surgeries
Surgeon need to do
Yeah.
to be excellent, an expert in this
Yeah.
kind of incision, because the difficulty is to create that incision.
Yeah, yeah, yeah. So you want to know the magic number?
Yes.
Okay. So I would say on an average you need to at least do 30 surgeries to get a fair idea of how to make a scleral tunnel quite reproducibly. Of course, that doesn't mean that you will not have any complication later, but that means that you will get certain idea about how to make a good scleral incision. Is that a good number? Okay, Dr. Caroline, yeah, I would like to show how I mark toric IOLs. Okay, so can you show a torch from side? मावशी माझ्याकडे बघा. Huh? So here what I am going to use is a simple app which I have developed. It's called iToric Patwardhan app. It is available on Android platform, free of cost. So you can use it anytime. So I just ask the patient to look straight, look at me, and I am going to do freehand marking. Okay, just like that. Okay, which is approximately at 0,180. I don't worry about the accuracy because I will show how I do the accurate marking. Okay, now can you focus on the mobile? मागे जा. Okay, so on my mobile I have loaded the iToric. I will just show you the app here. This is the iToric Patwardhan app which is on the Play Store. So I click on that. This is the app. Okay, now you have to use it like this. You can use the light. Moshi saral baga. You have to ask the patient to look straight. You can also check on the screen, mobile var dakho, that both the eyes are on the same level, so there is no rotation of the head. And now saral baga maushi, you ask the patient to look motte ugda dole, ask the patient to look straight, motte ugda motte. छान असेच बघा. Correct. So patient is looking straight and I click a photo. I pinch zoom. You can see on the screen here, Dr. Caroline. Okay, and this photo shows the 2 marks which I have done. Now what I do, I superimpose these red marks over these blue marks, and now the calculation is ready. Now in this case, I have to place the IL. Please tell the axis, Nidhi. So here I have already calculated the toric IL axis in the left eye, which is at 5 degrees. No, it's at 3 degrees. So I just enter 3 degrees here, but as you can see, there is no error in my marking. So it shows that the new axis is 2 degree. So if there was any error in 0,180 degree marking, it will correct the axis for me. Okay. So very simple to use. You don't have to use slit lamp. त्यांना झोपवा पेशंटना रेडी करा. तिकडे जाता. So there is no need to use slit lamp or any other method of marking. You can just use the same marker pen which is available, mark on that, and then use this app to correct the reference axis. So in this case I have to place the IL at 2 degree, and now along with that I will also use the Callisto. So let's see how accurate it is. Any questions about how to use the app?
The Arctic system
Magun
working
Banjar.
for phone?
Can you repeat the question, please? Staple.
Can we use this system with Android phone or
Yes.
only with the
Only with Android phone. So if you go to the Play Store and search for iToric, ITORIC space Patwardhan, PATWARDHN, you will find this app. You can just install it on your Android phone. It is free of charge, and start using it from tomorrow. And it's very useful for the the flow of the surgery, because if I have to do multiple toric IL implants, even the assistants can mark and take a photograph, calculate the axis, and I just have to mark it on table and do it. Of course, now I have access to Callisto also, which is a markerless system by Zeiss. So I will show that also during my surgery. कर लो. I think we don't have much time.
Surgery room. You don't need to do it outside with a slit lamp.
Marking. So I don't use slit lamp to mark. As I showed, I just did a freehand marking. So I just approximately mark 0,180 degree. Any error in those markings will be corrected by this app. So I don't have to worry about any errors. हात खाली ठेवायचा मावशी आता. Okay, So I'll move on to the surgery. In between, you can keep asking questions. Very well done, Dr. Umesh, for the small incision cataract surgery, I hope. So I wanted to ask, in Mexico, how common it is to do small incision cataract surgery, or you prefer doing extracapsular and then phaco? Okay. So it is much better option than extracapsular, definitely, because the post-operative follow-up becomes much easy. You don't have to suture the incision, and astigmatism wise also it works better. Okay. डोळे उघडा मोठे काही होत नाही घाबरू नका तुम्ही शाबास बस एक 10 मिनिटं लागतात हां चालेल आता अनवटीवर घ्या जराशी बस समोर लाईट दिसेल हां So I will also show the Callisto. I am not sure. I think he has put it on the different camera, so you will not be able to see the Callisto marking, but I think he can show it using the external camera there. Rishikesh, can you show using the external camera? Huh? अच्छा तिकडं राईटचंच आहे ओके थांब जरा ॲक्सिस दाखव मावशी घाबरू नका काही होत नाही पाणी मारतो ओके कॅन यू सी द ॲक्सिस विच इज शोन बाय द कॅलिस्टो हिअर डॉक्टर कॅरोलिन okay so you can see it's very close to what I have marked and 2 degrees is hardly anything, so I am not going to mark it again and we'll move ahead with the surgery. मावशी आता अजिबात हलवू नका तुम्ही So this surgery is on topical anesthesia. I prefer to do most of my surgeries on topical anesthesia. So this is again a 23 gauge MVR which I use. मावशी किती वळवळ करते. And I am going to use intracameral xylocaine which is preservative free. Light कडे बघा मावशी. हां हलू नका. Yeah? I can't hear. ओके आय विल CCC मार्कर 6 मिलीमीटर आहे रेडी आहे का नाही ना शोधावं लागेल ना या कॅन यू रिपीट द क्वेश्चन प्लीज लाईटकडे बघा लाईटकडे बघा या वी कॅन यूज दॅट CCC ऑन कर रहे सो बट there is another way I wanted to show, but let me see if my assistants find it. You can use also the marker over the cornea, which gives a very beautiful centration for the rhexis. Nonetheless, so this is the rhexis marker inside the Callisto which is there. But I find its accuracy is not that great and depends on, I think, if the patient was cooperative during the IL master. Okay, off. So another PSC, I hope it doesn't drop. Okay, so that was the hydrodissection. You could see the wave and then rotation. Now I will move on to phaco. You can see the parameters on the screen. I am going to use again I think 36 millimeter of IOP. मावशी पाण्यान धूत असतो काही होत नाही घाबरू नका रिलॅक्स राहा. Okay, another. Yes. I can't hear. हलू नका. So this is the primary chop. Chopper. Yeah, can somebody hear the question and tell me?
Where can we buy the Sinski?
Yeah, so this Sinski is modified by me, and yeah, of course you can get it made by any of the local instrument manufacturer. मावशी हलू नका. So I use different Sinskis. Like the previous case, I used a 1.5 millimeter long. हलू नका हलताय खूप. 5 मिनिटं राहिली फक्त. Can somebody repeat the question?
I think length of the Sinski.
Since this one is 1 millimeter long. This so I use 1 millimeter for most of my cases, while for very dense cataract I go for 1.5 mm. हलू नका. The patient is very uncooperative. आपला का त्यांचा? लाईट कडे बघा मावशी. हलू नका. झालं आता लेन्स बसवणं. If there are any questions, please keep asking. I can't hear you, but one of my colleague will listen and tell me the question. Okay, you can see that the AC becomes quite deep. Cortex वर आहे. So she has LIDRS, that is lens iris diaphragm retropulsion, and probably that gives little bit of discomfort to some patients. Yes, doctor. Yeah, please repeat the question because I am not able to hear the question.
Yes, you said that you have retropulsion.
Yeah.
So I'm asking if the patient has a myopic eye.
No, this patient doesn't have, but yes, it's more common with myopia and young patients, but we see in few patients,
Normalized.
yeah, even in normal eyes. So generally the intracameral anesthesia works well, but some of the patients still feel little bit of discomfort. though it's quite less when we operate on a low IOP system like Centurion. So now I am going to push the IOL. I use 1% hyaluronate in the bag, and that's because it's easier to remove it after placing the IOL. So this is a hydrophobic single piece IOL, which is a toric IOL. This is by an Indian company called Care Group, and what I do is I rotate it and keep it little bit,
How much astigmatism you can manage with this lens?
Yeah, so in India we are lucky that we can have even customized IOLs. Maushi halu nakata, and I have managed up to almost 13 diopters of corneal astigmatism using customized toric IOLs. Yeah, but the routine ones, Maushi halu naka, routine ones are available till 6 diopters, so you can manage up to 4.5 diopters of corneal astigmatism.
Okay, it's a good range, 13 diopters.
Yeah, even more than that if it is, showed me the callisto marking. So the patient has become very, very jittery somehow. Okay. So I will just finish the surgery. Maushi light kade baga. I will just hydrate the incisions.
Do you take the OBD over the lens
Yes.
to prevent the movement of the IOL?
Yes, over and under the IOL as well, and that's the use of 1% hyaluronate, because it's a cohesive OVD. It just comes off very quickly from the bag as well. Okay, I will just finish off this surgery because this patient has becoming restless. Vaigamo. Any other case? Okay, Dr. Caroline, I will just finish this case because this patient has becoming quite restless. Okay.
Yes, it's okay, yet, and it's very late.
Yeah. So I think we have finished 5 cases, and if there is time, we'll go ahead with another case. But if it's there is no time, we can finish off right now. Dr. Caroline?
Could you please repeat me that?
Yeah, so I think the time is over. So if you want me to do another case, we'll do.
We have some minutes, and I want to ask you if you can invite audience to watch your faculty's videos in YouTube.
Invite audience to watch your YouTube.
Yeah. So I have a very interesting channel by my name Saurabh Patwardhan, Phaco Tips. I hope that few of you are already watching my videos, and I have started maybe a few years back, and they have all the videos starting from basics to advanced, and lot of small detailed tips about small detailed tips about each and every surgery, right from simple steps to very advanced or complex cases as well. So do watch, and I would like to even interact through YouTube channel, so you can comment, you can share your views, and you can tell more ideas to us, because it's a platform where we want to share ideas and do better for our patients.
Okay.
Can I give?
All what is left is to thank Dr. Soro and Dr. Nidhi Patwardhan for your magnificent participation. We hope it isn't the last time can we meet.
Yes.
Thank you very much.
Thank you so much. Thank you so much.
Please
Doctor.
big applause.
And the College of Ophthalmology of the State of Puebla.
Thank you.
It's very pleased to have you here.
I hope it was useful, and hope we could show a few things which might be useful for your OR next time you go in your OR.
Sure, we will, and
Yes.
Thank you to your crew and 10 hours more in India. Thank you very much.
Thank you. Now it's the next day for us. It's already crossed 12.
Yes. Good morning.
Okay.
Thank
So,
you. See you soon.
so
Bye.
bye from the future. Bye.
तो ये करना है
हाँ, मैं कर देता हूँ. Thank you.
Bueno, pues. Muchas
Side
gracias
sir.
a todos por estar aquí. No los veo con esta luz, pero continuando con nuestro
ठीक है.
programa, pues me toca darles a todos ustedes la bienvenida a nuestro curso. Ustedes, los que están también en línea, pues es para mí un honor como presidenta del Colegio de Oftalmólogos del Estado de Puebla dirigirme a todos ustedes y darles la más cordial bienvenida a nuestro 35 curso anual de actualización en oftalmología, afrontando nuevos retos, que creo que es lo que nos toca después de la pandemia y todo lo que estamos viviendo como humanidad. Me llena de orgullo y emoción poder presidir en esta ocasión nuestro ya tradicional y reconocido curso,
डोळे उघडा काका.
que por su alta
बंद
calidad
करा.
académica se ha posicionado